You know, your shoulder is pretty amazing. It's the most mobile joint in your entire body. It lets you throw a ball, reach for the top shelf, lift things, just an incredible amount of freedom. But, and this is a big but, all that freedom comes at a pretty steep price: instability. So today, we're going to decode the most common ways this super complex joint can go wrong, breaking down some amazing insights from clinical experts.
All right, so here's our game plan. First, we're going to talk about the shoulder's fundamental design flaw, this big compromise it has to make. Then, we'll dive deep into dislocations and fractures, and we'll even explore joint replacements, including one that is, well, a truly bizarro solution. After that, we'll get into those chronic wear and tear injuries before we wrap it all up with the key takeaways. Let's get right into it.
So what is the fundamental problem with the shoulder? I mean, why is it so prone to injury? Well, it all comes down to a trade-off, a grand compromise. To get that incredible, almost 360-degree range of motion, you have to give something up, and what you give up is stability.
And this right here, this is the key. The price of mobility is instability. The best way to think about it is like a golf ball sitting on a tee, right? It can move in any direction you want, but it doesn't take much of a push to knock it right off. If you can just get this one concept, it's the key that unlocks pretty much every single injury we're about to talk about.
Okay, so let's start with the most dramatic example of that instability, a dislocation. This is when the ball of the joint literally pops right out of the socket. Now for doctors, figuring out how it popped out means they have to go into detective mode and look for some very specific clues.
And right away, you can see there's a huge imbalance here. It's not even close. A whopping 90% of the time, the shoulder dislocates anteriorly, meaning it pops out toward the front of your body. Because of this, the investigation almost always starts by looking for evidence of that kind of dislocation.
And here is our first major clue. It's called a Hill-Sachs lesion. So when the ball of the arm bone, the humerus, pops out forward, it smacks against the hard front rim of the socket. Then, as it gets pulled back into place, the softer bone on the back of the ball gets dented. That dent, that signature little fracture, that's the Hill-Sachs. Finding this is the absolute smoking gun for an anterior dislocation.
Clue number 2 involves damage to the socket itself. See, the socket has this soft cartilage bumper around the rim called the labrum, and it's there to add stability. Well, in an anterior dislocation, the force of the ball popping out often rips that bumper right at the front and bottom part of the socket. That specific tear has a name. It's called a Bankart lesion.
Okay, so let's put it all together. On one hand, you have the common anterior dislocation. It's usually from a simple fall, and your clues are that Hill-Sachs dent and the Bankart tear. On the other hand, you have the much rarer posterior dislocation, often caused by really violent muscle contractions like from a seizure or electrocution. The clues here are totally different. A trough sign, which is basically a reverse Hill-Sachs, and something called a light bulb sign on the X-ray.
Now, if that feels like a lot to keep straight, don't worry. Here is a fantastic little mnemonic that I love from the source material. Most of us know that hip dislocations, like from a car crash where your knee hits the dashboard, are almost always posterior. They pop out the back. Well, just remember this. Shoulders are the opposite of hips. Simple as that. It's a great little trick to remember which way they usually go.
All right, let's move on from dislocations to actual breaks, to fractures. When the top of that arm bone, the humerus, breaks, especially in older folks, surgeons have a really big decision to make. Do they try to piece it back together, or do they replace the whole thing with a prosthesis?
You know, the classic story is an older person falls on their outstretched arm. The surgeons will look at the X-ray and classify the fracture based on how many pieces the bone shattered into. Now, for the really bad 3- or 4-part fractures, there's a huge risk that the blood supply to those broken pieces gets totally cut off. And if that happens, the bone can't heal, which means a simple repair is just off the table. That's when the conversation turns to replacement.
And this leads to a massive question. A normal, traditional shoulder replacement is designed to copy your natural anatomy. A metal ball on the arm bone, a plastic cup for the socket. But here's the catch. It completely depends on your rotator cuff muscles to power it and keep it stable. So what on earth do you do for a patient who has a terrible fracture and a rotator cuff that's already completely shredded?
The answer is one of the most brilliant, most clever innovations in all of modern medicine. It's called the reverse total shoulder. And as the source material perfectly calls it, this is the Bizarro version. It solves an otherwise impossible problem by literally flipping the script on how a shoulder is supposed to work.
Okay, check this out. A conventional replacement, like we said, mimics nature. Ball on the arm, cup on the socket.
The reverse does the exact opposite. They put the ball on the shoulder blade and the cup on the arm bone. This completely changes the physics of the joint, making it so much more stable. And this is the magic part. It lets your big deltoid muscle lift your arm all on its own without needing a rotator cuff at all. It's incredible.
So, how does a surgeon decide? Well, it really just boils down to a pretty simple guide based on two key questions. First, is the rotator cuff okay or is it trashed? And second, is the socket bone, the glenoid, in good shape? If that cuff is torn to shreds, the path almost always leads to a reverse shoulder replacement. It's become the absolute go-to for these cases that used to be unsolvable.
Okay, let's switch gears. We've talked a lot about the big, sudden, traumatic injuries. Now let's dive into the much more common chronic problems. This is the world of impingement and rotator cuff tears, the stuff that's usually caused by years and years of overuse, friction, and just plain old wear and tear.
So you hear this word impingement thrown around a lot. It really just means pinching. And there are basically two main flavors. External impingement is when the tendons get pinched from the top, usually by a bone called the acromion. This can be made worse by bone spurs. Then you've got internal impingement, which is when the tendons get pinched on their undersurface. You see this a lot in athletes who do tons of overhead movements, like baseball pitchers or swimmers.
Let's connect a few more dots here. The most common type of impingement by far is subacromial, and that's the one that damages the supraspinatus tendon. In those throwing athletes, you tend to see that posterior superior internal impingement, and that pinches the infraspinatus. And if the pinching is happening at the very front, that's called subcoracoid impingement, and it damages the subscapularis. So each location has its own specific victim. Now, when all that wear and tear finally leads to an actual rotator cuff tear, where does it usually happen? Well, the data is pretty clear. Tears on the undersurface of the tendon, the articular side, are 3 times more common than tears on the top surface, and that's a really critical point when you're trying to figure out what's going on.
And finally, you might hear a doctor use the term massive rotator cuff tear. Now that's not just them being dramatic, it has a very specific clinical definition. A tear is considered massive when it involves at least 2 of the 4 rotator cuff muscles. Hitting this threshold is a huge deal for surgical planning, and it often points right back to that ingenious solution we talked about earlier, the reverse total shoulder.
Wow, okay, we have covered a ton of ground, from big traumatic injuries to these slow chronic conditions. So let's take a second and just crystallize all this information with a super quick review of the absolute key concepts you should walk away with. Here it is, your cheat sheet to shoulder injuries. You see a Hill-Sachs lesion, you should immediately think anterior dislocation. You see a Trough Sign, think posterior dislocation. Patient has no rotator cuff, the answer is a reverse total shoulder. And for all that wear and tear, remember that the supraspinatus is the muscle that gets torn most often, usually because of subacromial impingement.
You know, when it's all said and done, the story of the shoulder is really the story of this beautiful but incredibly delicate compromise. Every single time you reach for something on a high shelf or you throw a ball, you are using a joint that decided to trade rock-solid stability for this amazing freedom of movement. So my final question for you is this. After seeing everything that can go wrong, what simple, everyday shoulder movement are you going to appreciate just a little bit more today?